We'll talk just about pathologic Q waves here. So Q waves are the initial deflection in the QRS complex, anything that precedes the R wave. It's due to, in normal hearts, it's due to this left to right septal depolarization right here, but it can also represent disease. It can represent asymmetry in the electrical activity due to myocardial infarction, generally a transmural process, and then asymmetric hypertrophy, and a number of other conditions. So the conditions associated with Q waves are this: the myocardial infarction, that's the one we all think about. That can be recognized MI. We did have a patient here recently who just finished his Ironman triathlon, only to find out that he had had a heart attack about 10 years before. So it could be very much an unrecognized process as well. WPW can present with or can manifest some Q waves. Myocarditis, dilated cardiomyopathy. The thing I'll point out about that is that it can be either ischemic or non-ischemic, and about 10 to 25% of non-ischemic cardiomyopathy patients can have Q waves on their EKG. I'd mentioned before hypertrophic cardiomyopathy, about 40%, and that's the one study I looked at, had Q waves. They're often inferior-lateral. Isolated Q waves as the only finding can occur, happens about 10 to 20% of the HCM population. Some other causes: Chagas, sarcoid, infiltrative disorders, et cetera. And as John mentioned earlier, some lead placement issues. We'll get into that in just a little bit. So pathologic Q waves, the clinical criteria for pathologic Q waves have been geared towards detection of myocardial infarction. So when all of these criteria that were proposed years ago, they wanted to detect people who have had heart attacks. And they proposed various things. They looked at depth criteria, ratio criteria, width criteria, the number and location of leads. There's no consensus as to what defines a pathologic Q wave. The common definition has been greater than or equal to 40 milliseconds in width, RS duration of 25% or 3 millimeters in depth. In the context of screening, as we're talking about here, the focus is really on something different. We're not really geared up to diagnose the MIs. And so these traditional definitions of pathologic Q waves may not be completely appropriate. I want to talk real quick about this QS pattern that John had mentioned. It can occur as Q waves here in leads V1 and V2, and here in V3. This is commonly referred to as sort of a septal infarct pattern. And it can be associated with real pathology, but it's, as I'll show on the next slide, often associated just with sort of lead position. When I say lead position, it's not that the ECG tech has necessarily put them in the wrong spot, but as Joe Merrick had pointed out before, that the heart does have different positions relative to those leads, and just going by the rib position doesn't always capture everything that's going on with the heart position. So in our data, we had isolated QS leads seen in 2 of our 791 athletes, so the prevalence of that was 0.25%. We didn't see any in our HCM population. So this is the best data we have on this, I think, and this is a single author paper, which I was quite surprised by, but this individual had reviewed all of UCLA's ECGs over a 2-year period, and 2/3 of which were outpatient individuals, and they identified 99 of those were 0.2% with this isolated septal infarct pattern. They went forward and reviewed the medical records of these 99 individuals. 78% of them were female, average age was 62, and 15 to 20% of them had evidence of an MI, but 75 or 80 to 85% of them did not, so they were due to some other reasons. Now this is an older population, so all this data may not apply to our screening population, but the important part here is over 2/3 of them, or about 2/3 of them, the Q waves went away when they repeated the EKG, so it may just be as simple as positioning. Here's an example of some Q waves that we see associated with Wolff-Parkinson-White syndrome, and these are down here in sort of the inferior leads. You can see the Q waves right there. You should also note that the short PR interval and the delta waves, but when you see the Q waves, one of the things you should be looking for is this a WPW pattern that's being masked? I showed this before, the ECG findings in hypertrophic cardiomyopathy, HCM patients who had a prevalence in this study of around 40% or Q waves, and about 10 to 20% of them, pathologic Q waves was the only ECG abnormality seen. The problem that John pointed out before was this is really the problem of these tall, skinny Q waves, and this is the nemesis of screening, essentially. And So we get these athletes with hypervoltage, lots of LV voltage here, and they have these small Q waves. And so this is an athlete with left ventricular hypertrophy and a Q wave of 4 millimeters in depth. Over here, we have an individual with hypertrophic cardiomyopathy who's gene positive, who also has 4 millimeter Q waves. And so how do we, and we're talking about doing this on a population-based screening, how do we differentiate this person over here who's healthy and this person over here who has a potentially fatal disease? This is some data from Stanford, and it's done by Marco Perez's group down there. And they did a quantitative ECG analysis from their population of athletes and patients with hypertrophic cardiomyopathy. And they're comparing the cumulative frequency of the depth of the Q wave over here, or the width of the Q wave, showing the differences between patients with hypertrophic cardiomyopathy and in athletes. And you can see there's very small areas here. I'm just going to pull this up as an example. There's a very small area over here, sort of at the end of the spectrum over here, and this is in width in the inferior lead. Width of the Q wave in the inferior lead is once you go over 30 milliseconds, then you start to have more HCM patients have an abnormal Q wave than athletes. But the diagnostic sensitivity of this test is going to be pretty poor, because you can see athletes still have these Q waves out here. And so as isolated findings, it's going to be challenging. So can we find these optimal Q wave criteria for optimizing the sensitivity and specificity to make this a reasonable type of test to use on a population screening level? European Society of Cardiology proposed using 40 milliseconds as a cut point, except in leads 3 and AVR, and they said one or more leads, and that led to quite a number of abnormalities or abnormal ECGs. The Stanford group tried to refine this just a little bit. They used 3 millimeters or greater than 40 milliseconds. They threw in some extra leads that they were going to exclude, and again had a very high false positive rate. In 2013, we tried to, the Seattle criteria, we tried to refine this a little bit and use these, and we said greater than equal to 2 leads. We're still finding quite a few individuals with these abnormal Q waves due to the tall, skinny hypervoltage issue. So how are we going to improve specificity? Well, the newer criteria are really moving away from the absolute depth and absolute width and getting into the ratio criteria. And so ratio is over here, is looking over here. We're just looking at the depth of the Q wave and comparing that to the height of the R wave. And that ratio represents a way to normalize the whole process for the hypervoltage that may be occurring. So the refined criteria, this is Dr. Sharma's proposal in 2014, suggested using a QR ratio greater than equal to 25% of the ensuing R wave, or greater than or equal to 40 milliseconds in duration in one or more lead. And we adopted some of those, but we decided to go with greater than equal to 2 leads in the international consensus criteria. When we look at this in our population of patients and hypertrophic cardiomyopathy patients and athletes, we see that this is actually quite a good change. So if we're only looking at Q waves, and that's the only thing we're looking at on the EKG, the sensitivity goes from 13% up to 22%, and the specificity goes from 98.7 to 99.6%. But importantly, the number needed to evaluate, the number of abnormal ECGs that we're picking out and saying you need to be evaluated to detect one case of hypertrophic cardiomyopathy goes from 53 to 18 just by making that one change. When we combine it with all the other Seattle criteria that are involved, we still see the same improvement. And the number needed to evaluate goes from 41 down to 29. So with this change, we're not only getting improved sensitivity, we're also getting improved specificity, and we're reducing the number of athletes that we need to evaluate to detect one case of hypertrophic cardiomyopathy. So what are these in practice? What do these look like? This is that 22-year-old asymptomatic female who has played ultimate frisbee, and she has these Q wave abnormalities right here. And it turned out that this Q wave up here and lead 1 doesn't meet diagnostic criteria based on the conventional criteria, but does based on the ratio criteria. And because she only had the Q waves in 2 leads, it wasn't being picked out by the Seattle criteria. It's being abnormal. It's being picked out by the international consensus criteria as being abnormal. And this is that MRI that I showed you before. So I think individuals who have very isolated hypertrophy isolated a single segment, generally have less worrisome looking ECGs, but she's got a fairly aggressive truncating mutation here that puts her at risk, and the fibrosis assessment confirms that. So how should we evaluate Q waves? So first off, look for that WPW pattern. Make sure that you're not going to missing something that's being that's sort of hidden in there. And again, it's important to undertake the evaluation in the context of this low positive predictive value. So even with this ratio criteria that we're using now, it improves the sensitivity and specificity, but if that's your only finding on the ECG, your positive predictive value for that is on the order of 2 to 5%. Of detecting something. Now, if you have ST abnormalities, T wave inversions, and Q wave abnormalities, you're highly likely to find disease in that individual. Evaluation of isolated Q waves. We evaluate for the presence of pre-excitation. If the Q waves are isolated to V1 and V2, we recommend the repeat ECG before doing any additional testing. Again, do the history and physical, detailed family history. We'll look for coronary artery disease risk factors, cholesterol management if they have high cholesterol, smoking cessation if they smoke, et cetera. But if they have Q waves due to coronary artery disease, they've got some big problems going on, especially if they're young. Echocardiogram, we evaluate for the myocardial infarctions, dilated cardiomyopathies, hypertrophic cardiomyopathies, et cetera. We covered some of that before. Then on a case-by-case basis, we'll consider stress testing for ischemia, cardiac MRI for scar assessment, and subsequent evaluation is then guided by the above results. So Q waves result from normal septal activation, but can also represent significant pathology. The isolated Q waves in V1 and V2 often are lead placement related, and a repeat ECG should be performed before launching into additional testing. Traditional criteria for pathologic Q waves are not ideal for identifying the types of conditions seen in younger athletic populations, and criteria using these absolute Q wave depths result in a high false positive rate. Ratio-based criteria, as proposed by Sanjay's group in the refined criteria and adopted by the international consensus criteria, really seem to be the way to go in terms of improving the sensitivity and specificity of this, and hopefully make this not only fewer number needed to evaluate, but also then decreasing the cost involved with screening programs as well. Very good. Thank you very much.